Hi, everyone. My name is Elise Starks Daniels. I'm going to be talking about or doing my PowerPoint slide on the clinical management of alcohol use disorder. So, this is the epidemiology and public health burden. 29.5 million Americans face alcohol use disorder, and that's ages 12 and greater that actually meet the DSM 5 criteria. About 7% receive pharmacotherapy, so meaning drug therapy, to help treat this disorder. And annually, there's 95,000 deaths annually that the CDC has reported. And it is the number 3 cause of preventable deaths in the US. So, preventable causes of mortality. As far as like biological, physiological, social, and behavioral, we will go over those risk factors. So, family and genetics can play a serious role if you have a parent or a sibling that suffers from alcoholism. Just having that exposure is a big deal. And then early age of alcohol initiation, so whether it's like teenagers, young adults, even some children get that first very early. Neurobiological adaptation to chronic exposure, meaning that your body is used to drinking. So, and then also men are at higher or have a higher prevalence of alcohol use disorder. Um, as far as physiological things, so depression and anxiety, trauma and adverse experiences, alcohol can be used to cope with these things. Another coping thing that alcohol can be used to cope with is stress and emotional dysregulation. As far as social and environmental, if there's easy access, so maybe there's or alcohol cabinets that are not locked, and it's very prevalent in the house, peer or family alcohol use, or you're just, it's normal, it's everywhere you are. People, are providing access for you. It's just a normal thing. Or even social isolation where you decide that you want to drink and by yourself and no one's around to stop you. Behavioral risk factors can be binge drinking patterns, increasing tolerance, and drinking to cope with stress or negative emotions. As far as subjective and objective findings, subjective would be like things like strong cravings or urges to drink, reports needing increasing amounts of alcohol to achieve the desired effects, so increased tolerance, insomnia or poor sleep associated with drinking withdrawal, blackouts or impaired memory after drinking, and then reports of missed work, school, or neglected responsibilities due to alcohol drinking. And then, as far as objective findings, and these are things that you can physically see, so profuse sweating or even hypertension, so increased blood pressure, nausea, vomiting, slurred speech, difficulty walking sometimes, a flushed face, or um, seizures can even happen, or even hallucinations or psychosis. Tremors of your hands, too, would be another one. And also the alcoholic breath, so like the fruity breath that people always describe with alcoholics. As far as the DSM 5 criteria, this is what a person would qualify for to meet alcohol use disorder. So, mild would be drinking more or longer than intended, cravings or strong urge to drink. Moderate, these are the items that you would find for moderate, and then also for severe for the DSM 5. As far as these are just a few differential diagnoses that you would find in your DSM 5 book. So post-traumatic stress disorder, hypoglycemia, hepatic encephalopathy would be another one, delirium, and even thyroid metabolic abnormalities. As far as history, these are the types of questions that you would ask during your intake. And then these are just a few of the different screening tools that you would find. And then as far as the DSM-5 criteria, this just kind of gives like a time frame of each, and then even some of the labs that you would look for someone who is suffering from alcohol use disorder. As far as the neurobiology of the alcohol use disorder, this is just kind of like how you would see it like within the body. So like the effects would be, the increase in dopamine, the enhanced GABA receptors, and then increase endorphin release, opioid. So it gives like an opioid almost effect. And those are just a few of the acute alcohol effects. As far as like chronic use and neuroadaptation, you would see like, a decrease in GABA with, the increase in tolerance. If a person isn't getting that extra drink or extra thing they need, they'll see that will go down. And these are just like the different deficits that you'll see with chronic use, how these factors will change. As far as with evidence-based screening assessments, these are the tools that I discussed earlier. So there is the audit and the audit C. The audit is just like a quick screening questionnaire that just goes over a couple of questions. The audit C, the audit is the gold standard. So that is like the large list of questions. The audit C is the abbreviated form that you'll find, and it's a brief questionnaire that goes through the questions for someone that might be in, in a hospital setting where they need to get a intake. So those are just ways and mechanisms to get patient information. And then you also have the CAGE, which is also another tool or screening tool or assessment, and the CIWA, which is another screening tool and assessment. As far as psychosocial interventions and evidence-based approaches, there's motivational interviewing is one evidence-based approach. And then there's also cognitive behavioral therapy, which is used to, help or try to get to the root of the cause of drinking. That can be used a lot of times. A referral is put in for a therapist for cognitive behavioral therapy. And then the motivational enhancement therapy, it match trial validated. It integrates normative feedback and client anatomy. And then you have the 12-step facility approach, which is another approach. And then you have contingency management as well. And then there's also a comprehensive clinical assessment for alcohol use disorder. So first, you're going to get their drinking history, any withdrawal risks that they may have, a laboratory workup, any psychiatric comorbidities, and then also their functional and social status. So this just kind of goes over what all of these would encompass. As far as potential abnormal findings, there are hematological, so just a few that would fall under that would be anemia, thrombocytopenia would be another one. Macrocytosis would be elevated in the event there was a heavy drinker. Hepatic labs, so those would could potentially be abnormal, metabolic and nutritional, and these just go over the items that you would find under those areas. Neurological, and these give a few of the items that you might see, and then just a few other complications. As far as alcohol withdrawal, this just kind of goes over the clinical timeline and management that you would see. So 6 to 12 hours, you're going to see autonomic hyperactivity, so tremors, sweating, maybe an increase in heart rate and blood pressure, anxiety, and insomnia. And then 12 to 24 hours, alcoholic hallucinations, maybe some visual, auditory, tactile hallucinations. And then after 24 to 48 hours, you may see the tonic-clonic seizures. And then 48 to 96 hours, delirium, tremors, etc. So these are just a few things to look for. This kind of goes over first line pharmacological uses. So these are the benzodiazepines, which I know we usually try not to use those, but those are the first line defense mechanisms for seizures. And then as far as FDA approved medications, there is the naltrexone, and this just goes over the mechanism, dosing, efficacy. There's also 2 other medications as well. So acpromazite, and then there's also what we call it antabuse, is the other name for this medication as well. As far as off-label pharmacotherapy, these are the other items that providers may use. So Tepramate is one, gabapentin is another one, naltrexone plus bupropion is another one. And then these are a few that providers typically try to limit use of. And then special population and co-occurring disorders. So pregnancy obviously is going to be a high-risk patient, elderly adults, patients with hepatic impairments, and adolescents. And then this talks about the psychiatric comorbidities that can come with this disorder. So anxiety disorders, bipolar is another one. So as far as education, health promotion, psychosocial care, these are areas that we want to promote. So as far as patient education, letting them know that alcohol use disorder is a treatable chronic health condition. It's not a failure. It's not something that you can't overcome. Making sure to discuss the risks of continued alcohol use, and teaching the warnings of alcohol withdrawal are big and important. As far as health promotions, promoting nutrition optimization, thiamine and folate supplementations, physical activity, sleep hygiene. If they are smoking, and sometimes smoking and alcohol can go hand in hand, but smoking cessation, those would be the biggest ones. And if they're, for some reason, are hospitalized, making sure that they understand if their thiamine level is low, they might receive IV thiamine while they're in the hospital. As for psychosocial needs, evaluating family relationships and stress, assessing employment and school impact, identifying any social support and strengths, and screening for depression, anxiety, and trauma are a big thing for this population. Also doing suicide risks is important as well, and develop relapse prevention plans and crisis safety plans. And then also making sure that referrals and follow-ups are available. So addiction medicine specialists, behavioral health psychology, psychiatry for co-occurring disorders, any social worker case management, nutritional services, liver and GI specialists, community recovery programs. So those are just a few to name. And then last, these are the references that I did use for this PowerPoint. I hope that you enjoyed it, and that concludes alcohol use disorder.